There's a question about which patients are most optimal for BTK inhibitors as opposed to, let's say, a BCL2 inhibitor. And I think the things to note are that the BTK inhibitors are very reliable, and they've got a low risk of tumor lysis syndrome. In general, they can be given to patients who are older, who have got organ impairments, and they're very easy to give. So, and they're probably particularly applicable in patients who have got adverse genetics. So we know that the BCL2 inhibitors are effective in patients with adverse genetics, including 17p deletion or unmutated IGHV. But the data from studies such as CLL14, the German study, suggests those patients who carry those adverse abnormalities do have a slightly inferior progression-free survival compared to patients who are of standard risk. Whereas for the BTK inhibitors, most studies suggest that it's able to neutralize the excess risk of either 17p deletion or IGVH unmutated status. So I think the BTK inhibitors in general are more safer, easier to use, more blanket coverage across all categories of bad CLL. But of course, the BCL2 inhibitors have the advantage of having very deep responses, of being still effective against the adverse varieties of CLL, although maybe less so than standard CLL, and also has a distinct advantage of having time-limited therapy. So patients are always welcome the opportunity to come off the treatment and not have to have indefinite therapy.